Okay, thank you very much for joining the Kirby Institute seminar series, and this is our World AIDS Day seminar. Over the last couple of days, I've been to a lot of events commemorating World AIDS Day, and there's been a lot of talk about successes and initiatives within this country, but there hasn't been a great deal of focus on the region. And so we felt that our World AIDS Day seminar should concentrate on the region. And today we're lucky enough to have a presentation from Rachel Devi that will do that. So before we start, my name is Tony Kelleher, and I'd like to start by acknowledging the traditional owners of the land from which we are all meeting, and we are presenting from the lands of the Bidjigal people. I'd like to acknowledge those lands were never ceded, and I'd like to pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islander people who are joining us today. So the format of this seminar today will be that Rachel will make her presentation on HIV in Fiji, the situation and response, and that will be followed by an opportunity to pose questions and for Rachel to answer those. And the way to do that is to add your questions to the Q&A box that is on your screen. So Rachel Devi is the current head of the Family Health Unit of the Ministry of Health and Medical Services in Fiji. Rachel graduated from Fiji Medical School in 2007 and has a Masters of International Public Health granted in 2017 from the University of Sydney. She is currently pursuing a PhD with the University of New South Wales, and she's worked in various roles with the Ministry of Health for the past 17 years and has held her current position for the last 3 years. Over to you, Rachel.
Thank you very much for the opportunity to talk about the Fijian context. And sorry, having said that, all protocols observed. I'm sitting here from Fiji, Wilovinaka. And yeah, once again, thank you for the opportunity to share from the Fijian context. And I probably might tip into a bit of the Pacific where I can. And today I'll share on a number of things in relations to HIV, and I'll associate that with injectable drug use in the country and progress on that. Thank you so much. So I've got a few contexts to talk about, but firstly, I'll just take you to a tour of the island. The Fiji is an island nation, less than 1 million population. In the last 2017 census, we had about 887 individuals, and they across the 300 islands of Fiji. Majority within the Viti level group that you can see on the map there, and secondly in Vanua level. And having said that, if you've ever been to Fiji, within the Suva-Nusuri corridor where you see Suva, there's a star there. Within that corridor of about, say, 15-20 kilometers, almost 60% of the population live in this area. And life expectancy around 67 years. Our major crisis in the country is non-communicable disease, climate change, and HIV is definitely on the rise for us. And obviously cervical cancer also leading cause was death in women, one of the second causes. I just wanted to share this slide with us just to have a better understanding context of the Fijian background, the health systems that we've got in the nation. Having said that, this is the map of two islands, the two largest islands, and where I'm sitting out of Suva, the largest island, the city of the capital city of Fiji, and Viti Levu. I'm just sharing the structure of the health system. We've got our national office, and then this map, as you can see, it's divided into four places: Central Division, Western Division. That's where the airport is. Central is where the capital is. And then Northern Division is where the second largest Vanuatu you can see on the map on top. And Eastern Division is basically the maritime, the larger maritime that you can see. And within these sites, we've got divisional hospitals, tertiary hospitals. And within that space, for example, within the Central Division, we've got townships, subdivisional hospitals, we call it. And within them, we've got health centers and nursing stations that actually mentioned in the map. As I say, there's a reason I'm sharing this. I'll, as I progress, I'll dwell on it a bit more. So the Pacific and every other region, HIV remains obviously a global public health issue, having claimed more than approximately 42.3 million lives to date. An estimated 39.9 million people are living with it at the end of 2023, and 65% we know predominantly are within the African region. And in 2023, an estimated 630,000 individuals died from HIV-related causes. And I just wanted to point out that Fiji, being such a small island nation, almost 0.01% was contributed by Fijians, from the UNA's reports that we've had in 2023. And when you look at the global picture, basically, I mentioned earlier, this is just graphically showing you what I shared earlier. And just having said that, when you look at this, this is the cascade that we talk about. If you are in the space of HIV, you'd know this. Within the cascade of HIV, we've got this 1990 global strategy that we aspire all towards, when 95 at this point in time, as we move towards 2030 SDGs. And by now, by 2030, we would have reached at least 95% people screened for HIV. Of that screened, 95% of them tested positive to be on treatment. And then of those 95% of them on treatment, they should be at least virally suppressed. But the Western Pacific region is quite far from it. And having said that, these are estimates, so the suppression's quite far from it. And I will share Fijian data as we progress as well on where we are in this space. And having said that, when we look at deaths, HIV-related deaths globally, one thing you'll notice that every other region, gradually it's coming down over the past some years. But in the Eastern European region, the Eastern Mediterranean and the Western Pacific specifically, I'm picking out here, we've risen in our numbers of deaths over the past some years. And in 2022, we had 52,000 deaths. In 23 alone, we had 53,000. And this is predominantly contributed by Papua New Guinea, Fiji, as the others don't have that many cases as we speak. And are we on track? We're definitely not totally on track, especially not Fiji. I'll talk a bit more about why we're not totally on track. But these are some things that we're aspire towards. And I'll build up on why I'm saying that. So from the Fijian context, just the situation that we've got a prevalence of about 0.3, an incidence of 62 per 100,000 individuals from the census data we've got. And when you look at numbers cumulatively, Fiji's first ever case was recorded in 1989. Gradually, we've been increasing numbers every year as our testings got higher and rolled out nationwide. But obviously, there's been a lapse in the period of where things had mellowed down a bit for unknown reasons, and a number of various other things as well. And in 2024 alone, I just wanted to share this data. In 2024 alone, from Jan to June, I'm sorry, I couldn't share any earlier latest data, but from Jan to June, we had 552 individuals that were tested positive for HIV alone within that 1 6-month period. And this definitely surpassed year numbers from the previous years. And there's a number of reasons that has contributed to this. We had a significant rollout of point of care testing in the different divisions. like I mentioned earlier in the map, in the Western, Northern, Central, the Eastern divisions. So we rolled out point of care through the sexual reproductive health clinics. We scaled up more confirmation in the town areas, etc. So definitely we're seeing that, but obviously I'll share the transmissions as we progress. But having said that, in the last 8 years or so, we have seen almost a 573% increase from 2017 to date in numbers. Having said that, I mentioned the 2024 data is only Jan to June, and we're hoping to release our now at least September, October data by 1st of December. So you can watch this space, because definitely we'll make headlines, unfortunately, again in this space. But that's getting to know our HIV individuals' cases in the community is important for us to progress anyway. So we are anticipating a significant increase because of the scale up that the country's been doing. I'll just break down a bit into the 552 individuals that we tested positive this year alone for the 6 months. 540 were 97% were adults, 3% were children, and out of them, 6 were about mother-to-child transmission. We predominantly, 69% of our patients' cases were from the Central Division, followed by Eastern, where were just 2 cases. But having said that, that's the island area, so they're not exempted from HIV as well. Western Division had about 27%, and Northern, which is the second largest island, has had about 3%. And when we look at that, we need to make sure, obviously, they match up with the point of care, with the care as well, with our health facilities. So yeah, just to break down further. Now, if you, in Fiji, there's about close to around 21 town areas, and no single space is exempted from HIV. I'm sharing this data. Apologies, we're still cleaning up a number of data sets here, especially with the unknowns that you can see right on the left-hand side. And we're trying to sort this data at the subdivisional level. We've got divisional, but on the subdivisional level is where town areas where we're trying to sort this data. At least we know where it's somewhat in terms of targeting population as we progress. Gender distribution, we've got about 69% males, 30% females, 1% transgender. But having said that, these are individuals who identify themselves as transgender. So, but we do ask this question. Now, when we look at the gender distribution, this is something that's been of interest for us in the last year or two. Predominantly, when the HIV situation in Fiji started, we've seen almost a 50% of male and female. It's just over the last 3 years or so, we've been seeing a leap in male population compared to the female, almost a 70-30%, especially this year alone in the first 6 months. Now, what's happening in this space is unknown. One of the things I can 100% guarantee, there's about 20,000 women in Fiji that book every year through antenatal clinic for their first booking. And during this period, they actually do get their HIV test done. And you can, so first you can imagine that 20,000 women are already getting tested. So that's a good population as we speak. So there's something happening in this population that's unknown to us. It's either there's more MSM activities, or there's something happening. We are getting data in terms of where we're getting more testings done. Is it the male population, the female population? So I believe a lot more crunching of data is what we're trying to do right now to confirm and progress with the work in this space. But having said that, this is a research gap that we have in the country as I speak. Now, when you look at the age population, it is a pretty young population that's being affected in when it comes to HIV for us, and the dynamics are that it's moving more towards the left-hand side, as in the younger adolescent age group as well. Just looking at and predominantly it's between the age of 20 to 44 for us, 49 for us. For age distribution for HIV in the country. And this is just 2024, but I will share a bit on how things have progressed for our young people as well, because there was a time we barely saw any cases in the age of 10 to 19. but this age category is increasing as we speak. Now, when you look at this, just have a look at the way the graph will be shifting. The numbers will be shifting more towards in increase on the left-hand side, especially the adolescent age group. And when you look at 2022, we obviously, it wasn't so high. We had 6 cases at that point in time. Obviously, still within the 20 to 40 age group categories being significant. And when you look at 23 alone, our 15 to 19 increased. Our PPTCT, unfortunately, we still have cases. And in 2024, you can see the increase again from 30 to 50 from the 15 to 19 population. So gradually we are seeing an increase in this younger population. What's happening in this space? A lot of, there is consensual sex, of course. We do also test our sexual assault cases. And test them for HIV and give them any prophylaxis where they become eligible. But having said that, that younger population for us is increasing as we speak, especially this year. Now, main mode of transmission for HIV has been sexual transmission. And you will see a good unknown there because a lot of individuals may identify as and may not tell us, but predominantly we know it's been sexual. But having said that, for the first time in 2024 alone, we have seen injectable drug use. And people, it's been there. I would not deny that it hasn't been there. But now people are coming up and accepting that, yeah, okay, I did use drugs and, injectable drug use. They've shared needles. And they've actually even, there's something that's happening in Fiji called, you may have heard of chemsex, but Bluetoothing is something that's new within this population of ours. And it's been happening for, this year's come out quite prominent, but doesn't mean it wasn't there before. It's been spoken of in the last year or two. And Bluetoothing is basically where individuals get high themselves with drugs, with the injectable drug use, meth or ice, and they literally withdraw their blood and share it amongst a group of people. So there's probably a gang of individuals, kids or adults, whosoever, and one gets high and then they share withdraw blood and share it with the others. And obviously we know how dangerous that is. And we've got this practice through different sources. And while we presume that may be contributing to our HIV cases because of this, the nature of it in itself, but now more individuals are identifying themselves as having used drugs in Fiji. And this goes also for pregnant women and our inpatient patients in the medical departments, etc. So predominantly sexual transmission followed by injectable for us, about 15% this year, and anal and other mother-to-child transmissions as well. Now, when we look at ethnicity in the country, our predominant ethnicity affected is about 89% is in individuals of, Itoke population. That's our indigenous population, followed by about 9% of Fijians of Indian descent and 2% others. And 2% others could be Asians, etc., that residents in the nation. And it could be even Pacific Island countries who are students in Fiji at any point in time of during this period, actually. One of the things we do need to explore a lot more is if we're testing, which population are we testing more? Because one of the things we're noting is that it could be that Fijians of Indian descent are naive to things and not coming forth for testing. Or are we getting more Itoke population that are coming out for testing? So there's a few things to look into here. But having said that, the 89% in indigenous population has been there. Predominantly, our ethnicity for distribution for HIV has been in this manner. Now, when we talk about co-infections, TB-HIV for us is a very common co-infection, and in 2022 we had 35, 23 about 60, 24 was 17 in the month of Jan and June. But we are getting a lot of verified data as we speak. So once we get verified data incoming, we know will definitely hit a high mark this year for TB HIV cases. We've just had some recent meetings which have highlighted some important findings. So that's important to note. Our TB HIV cases are prominent. And we do have multi-drug resistant TB in Fiji, so that's even more worrying for our HIV patients as well, and our TB patients, of course. With this co-infection, mortality is quite high. Now, AIDS-related death, I must say, it's unfortunate, but in an era, four decades down the line, when we've had medications, and Fiji does have medications, and is provided free by the government, in this era, we don't anticipate to see this. One death is too many for us, or anyone, especially when there's medications available in country. And we've seen the highest death in 2023, about 82 individuals, but this still could be lower. In 24, till June, we had about 13. We are anticipating this to get a bit higher because we're verifying data, as I mentioned. But even seeing this it's heartbreaking, especially for us HIV clinicians, because we should not be seeing any single death in this nation. But there are different contributions to this, and they are a bit anecdotal as well. In the sense, well, we're not just anecdotal, but some case studies we've had where patients would turn up to health facilities and unfortunately not be tested despite coming in frequently. And this is historically seen, and that's one of the reasons why we had to step up and train and upskill our staff in this. So, I mean, I myself had a 18-year-old kid that died in ICU with TB HIV, but he had been to the hospital several times, unfortunately. And these things kind of prompted us, okay, we need to train up our clinicians on the ground in public health space, in the tertiary hospitals, and be a lot more suspicious of HIV signs and symptoms, especially with repeated admissions, etc. Because that could prompt us. And people obviously will present differently in any clinical setting. But for us, that was something that we saw. And obviously stigma and discrimination issues are there in Fiji. I would not deny it. There is still stigma and discrimination. There was a time when I'd walk into a hospital and people would say, oh, there goes Rachel, and she's and they know that I'm a HIV doctor. And obviously they'll, that goes back to me as well. They put patient and me together to know what's happening. But it's not the case anymore. It's more commonly, openly spoken of. Confidentiality is quite a lot better than what it was 10 years ago in this space. Now, I did talk about the 95, 95, 95 data. For Fiji, unfortunately, we are there, but within the HIV data space, we've got the latest data. We've got about 84% that are retained in care from those that were tested. Of that, about 39% are on treatment. Virally suppressed, and then about 84% of those on treatment and 39% virally suppressed. But of those that are diagnosed, unfortunately, 33% are on care as we speak, which is unfortunate. We are losing a lot of people to processes, systems in place, information not getting to patients, and people not turning up to get their results. And I must say, Fiji has more mobile phones and numbers than there are people in this nation. So people change numbers, phones, like they change clothes sometimes. So and we're very mobile. We're a mobile population. People move from one side to another, or from the village to the city, or from the city back to the village because of financial constraints, etc. So there's scenarios are very different, and that literally contributes to a lot of this. And even to the point we had sexual reproductive health clinics in one division itself. So, and just linkage people to the care is always a difficult task. So these are areas that we've been noticing, and we're strengthening this space, basically. Just for 2024 alone, for instance, if there were, out of this 552 individuals, 50% are in care on treatment, 16% are not. So there is still a 45% not enrolled in care, and about 2% that had died, unfortunately. So this is the area, the treatment arm, that we're really trying to strengthen as we speak. Apart from testing, as we strengthen testing, we need to make sure and ensure that that this arm is absolutely strengthened with a lot of mobilization, a lot of communication, a lot of coordination across health facilities that I shared earlier in one of the first maps of Fiji, because they could be tested anywhere in the nation. But having said that, linking them to care is essential for us. And I'll share a slide later on talking about that. Basically, linkage to care, there's a delay in linkage to care from subdivisions, which is the town areas, of about 17 to 74 days. Blood bank itself, because of confidentiality context and not probably no proper counseling of referral mechanism, like just to be able to refer patients from the blood bank to the hub centers, which are HIV specialist clinics, that could go for almost 2 months. Divisional hospitals could be almost 20 days to 2 months. Health centers, which are smaller, could be more than 2 months. So yeah, it's varied, but the delay in linkage to care is huge, which actually contributes to the significant loss to follow-up of patients. And these are data that we've recently crunched up this year. And we're addressing this now as we speak to strengthen just that coordination mechanism in the ministry, in the country. Having said that, I just wanted to mention that Fiji, almost 90%, 95% of our healthcare system is public, where everything almost is provided for free except for dental services. Otherwise, everything else is free. And that in itself imposes some challenges as it is. So what has happened? What are some of the big wins for us? I mean, I think, I've been harping about HIV in Fiji for the past decade, and I've been trying to get some traction. And one of the biggest wins for me personally for HIV was the fact that the government recognized HIV and drug use as an issue. And if you go back to media in 2024, earlier this year, late last year, the government recognized that, okay, HIV is there and HIV is an issue. And then came about the drug issue. And obviously, if you've ever followed Fiji news, you would have heard of the drug busts currently recently that have happened in the nation, of more than $1 billion worth of drugs that have been caught. ICE basically, and even the largest I believe it is the global largest catch of in Spain, where they got drugs that was actually supposed to be shipped to Fiji, and we know from Fiji a lot of it predominantly goes to Australia and New Zealand as well. And these are from that part of the world. So just the recognition of HIV and drugs for us. And one of the ways we actually were pressing on for HIV was that we made sure at least quarterly, Fiji would release the HIV statistics publicly and make it known to our leaders, our media and people. So that was one way we literally got traction in this space. In terms of partnership, what do? We have a government ministerial departments that we work across. It's restart to a whole of society approach collaboration for us with universities, faith-based organizations, development partners, UN agencies. We even work with research institutes locally and internationally, and we've worked with Kirby as well. We've been in touch with Kirby, with Professor John and the others, and Burnett and FNU locally, and obviously we've got a lot of community engagement happening. But we know that in order to, like, literally, in my opinion, the response to this should be almost like a COVID-like response for us in Fiji, where we increase our resources to mobilize. While we're doing this through this partnership context, we know we can, there's a lot that still needs to happen in this space. The country ownership, so basically we do have a HIV Act, a very strong act. But obviously there are loopholes when you develop an act for the first time, and it's very internationally, it's renowned and quite strong on stigma discrimination for HIV individuals who are infected and affected by it. But having said that, there are some clauses which do need tweaking, which have affected our service delivery context and information sharing. So that definitely needs a review for us, and I'll share a bit on that later. But we've also done a surge strategic plan for not just HIV. There's on harm reduction as well. There's a narcotics strategic plan that's there. And both the strategic plans have been endorsed by Cabinet for us. And we hope to launch our HIV surge strategic plan pretty soon. It's a commitment by the Honorable Prime Minister himself. And because of that commitment, he's actually mandated a subcommittee by the Parliament of permanent secretaries. Permanent secretaries are equivalent to, I believe, CEOs, your chief executive officers for health in different states. basically. So for us, our permanent secretary is equivalent to that. And obviously the HIV board has an oversight of everything we do. Within the surge strategy, we've now got two subcommittees that we're developing. One is for the prevention arm and one is for the treatment care. And obviously the need for, we have increased in HR, but obviously we're still very understaffed to be progressing. So while I've said that there's still gaps and challenges in place, while leadership and governance, well, in that context, we know we need the act reviewed. We know we've got finances that we need. We literally need tons of money to be invested into this. We've got currently no information system to get this data going, apart from what we do from the laboratory context. Our medical products, vaccines, technologies. One of the things that's really affects us Pacific Island countries or small island nations is the purchasing power. Or even not being able, if you don't plan well, our purchasing power literally gets in the way. For example, if Fiji, like as you saw, Fiji had about what, 650, 630 individuals who are on treatment. No pharma company would want to develop or produce products for a country small like Fiji. So our prices of production literally go up for just one small country. So because of that, we've always found difficulty, and even people bidding, even leave aside price, even people wanting to bid for that small quantity is very difficult. So and that goes for kits as well as for medications as well. So that's been a challenge for us. And obviously, our health workforce is we've got basic HIV training, etc. We still need to strengthen this space up. And currently, it is the service delivery for HIV patients is decentralized. It is across the country. But having said that, it's not as decentralized as one would want it to be. For example, it's not at every single hospital that it needs to be at to be able to strengthen the linkage to care. So these are some things that we're working with. Opportunities, obviously we know HIV has no cure right now. Vaccines are being done, trial phases, etc. But obviously we've got access to effective HIV prevention, diagnostics, treatment and care, including opportunistic infections. So these are all something that we do in country. It's available. Obviously, we've got the narcotic strategy. We've got the surge strategy. We've got a budgeted plan for the meal with a meal framework, which I must say Kirby has contributed to. We've got national and divisional personnels at the SRH clinics who are quite competent, I'd say, because we literally in Fiji now looking at WHO guidelines, etc. We develop our own guidelines, our training materials, we train our own people. So there's a lot of trainings that individuals have gone for abroad locally. Definitely, we know there's government commitment. We know we can leverage on public-private partnership. We know we've, like I mentioned, updated guidelines, SOPs we're working on. One of the things that's really recently that's happened earlier this year is we've got a UNDP signed agreement that addresses the purchasing power that I was mentioning about. And with that contract, basically UN system, it basically becomes pooled purchasing for the Pacific, and also for the region or globally as well. For example, we purchase out of UN system, and this happens probably out of Copenhagen or somewhere where their stockpile is usually. I know UNICEF is in Copenhagen. I'm not sure where UNDP is, but with that comes about stock that we purchase out of what stock they have as well. And this will, I know this year, coming next year, will fine tune and iron a lot of the issues that we've facing in terms of procurement for our medications and testing kits, etc. We've got a donor care coordination committee that we have with our UN agencies here through the unit, and we do have a stigma discrimination report, but it's old, needs more work there. And obviously there's opportunities of master students locally and internationally to do more studies around this space, which helps us in terms of making policy decisions and implementations. I just wanted to bring this up here. These are some of the things that we're doing as we speak. And we're doing an integrated biological behavioral study in 2025. Actually, we're kicked off in 2024 now as we speak. We've just finalized contracts, etc. And this will, the last study was done in 2012. So it's been more than a decade. And there's a lot of information that's changed, probably dramatically or slightly, we don't know. But This study here will, it's with key populations, the LGBTQI population, and it'll give us a lot of information in terms of our population estimates, our biological context and behavioral context as well, because we do know condom utilization is low as well in Fiji. So it'll literally tell us a lot of policy, programmatic data information in the coming year. And apart from that, with the, I believe this rapid assessment for drugs in Fiji is also, it's happening as we speak. It'll roll out and in 2025, but this has been awarded to Kirby, and we're working with the team at Kirby on this one. And obviously, one of the things that we've seen that important research questions that we really need answered is the rapid assessments of prevention of parent-to-child transmission of HIV. What's happening? Why are we missing these moms, especially when we test them? Do we need to step towards 2 testings, first trimester, third trimester? So these are things that we need to look into. And also some retrospective review of HIV-related data and related deaths, etc. We need to look into that as well. And obviously, I think we need to go back and look into the stigma discrimination index study, because it has been more than about 8 years now that that's lapsed. And obviously, a lot of things have changed in the space. So I thought I just wanted to share this context. I'm not going to dwell too much on this, apart from the fact that we are trying to, through the meal framework in the search strategy, we are trying to approach this from a health systems approach, working across various areas, various sectors in the ministry, and working towards, and not just it will pitch into a number of other things. But just having said that, I just wanted to leave the fact that we do have some strengths and opportunities with the leadership, partnership, and ownership of this response. But I must say there's a lot of work that needs to be done, and it needs to be done at an escalated rate, which I believe is needed for this nation. Because one of the things that really happens for us in Fiji is we become the hub of the Pacific. And being the hub of the Pacific, we've got a lot of Pacific Island countries, students who come and study here in Fiji with us. And I have seen personally myself, Pacific Islanders who've tested positive in Fiji and gone back to their countries, HIV positive. So these are some things that we really need to work with and build up on. So while there's opportunities, it needs to be done at an upscale level, like literally escalated level that needs this response. And if I had my way, honestly, we led the COVID-19 vaccine response in Fiji through this unit that I lead. And it was basically a all of government, all of society approach, where we brought in everybody to, upscale, implement, and literally roll out, which actually helped us to bring, to that 95% of vaccine coverage in Fiji. But, and I think personally, we need similar response to be able to do this. If I had my way, I think, it'd be really amazing if every one of us knew our status, and if we were negative, we maintain it. If it's positive, we do something about it. Because we're losing too many young people, which obviously has a huge economical impact in the near future. Unfortunately, we are seeing the older generation burying their young, and that's disheartening for us as clinicians in this space. There is a number of things done. There is the search strategy is something that we're implementing as we speak. So I think I'll leave that basically brings me to the end of my presentation, and it's something that we are responding to in Fiji as we speak. World AIDS Day is going on. We're actually having our main celebrations, our commemoration on the 6th of December, and where we will soon launch our search strategic plan pretty soon in the months to come. But having said that, thank you so much for the opportunity, Tony and team, for me to share the Fijian context with you all today. Naka.
Rachel, thank you very much. That was a terrific presentation based on evidence and data, but with an insider's perspective on all this, which I think is just extraordinarily valuable to all of us. to get those, on the ground insights to what's going on. As I said at the beginning, the question and answer box is open, and I encourage you to add questions to that or to upvote questions that have been entered. Rachel, the first question comes from Greg Dorr, which is there any consideration for emergency department HIV testing or surveillance?
We actually do. Now with emergency department, they do testings on site where they, it's not for every patient, it's where there's suspicion. So they do that. And we currently, it's basically clinician discretion. And it's obviously, it's an opt-out context as well. Yeah.
Mm-hmm.
But we do definitely do that. And one of the things we are moving towards is we've started rolling out point of care testing in a lot of sites. And emergency and labor wards are site working towards, and including ANCs where we're working towards for point of care testing. Reason being because sometimes obviously the processes are long, after hours, there's no lab technician on site. So point of care testing for us, at least an immediate test, screen positive, would help the clinician make a better diagnosis and progress the patient further. And that's a challenge with resources, but as resources get better, I know this will definitely improve.
Thank you. Can I ask a question about the numbers you had in terms of risk factors? And there were a large group, in fact, the largest group was unknown. What do you think are the drivers of that? Is that limitations to the ability to collect that data, or is it around stigma and or is it lack of education and understanding about how this virus is transmitted? What do you think are the drivers of that huge fraction?
That's an absolute, I mean, this is something that we're always working with, and it's multifaceted. I think it's there's a lot of reasons for it. Like it could be stigma, discrimination. The other thing is, having said that, there's, if you look at my linkage to care, that is poor in itself.
Mm-hmm.
In a year, we almost have 50% that are not linked. And when you look at that, that is a good chunk of that linkage to care. And we need to strengthen that linkage to care to be able to identify that large unknown as well. Some may identify, some will not. Some probably clinician discretion, they may not have asked openly, they may not have counseled appropriately or being able to open up enough. So it could be multiple reasons to it. But one of the things we're noticing when we're looking at the linkage of care context and treatment linkage, we're seeing a good, unfortunately, we have been seeing a good 50% or so that are not linked. And because of that, it definitely gives us a good large number of, unknowns in this space. And this is where the ministry is working with not just that one clinic that looks after the sexual reproductive health clinics, but we're working with every single hospital within that division and health centers and trying to make sure we link them ASAP and decentralize even our treatment care as well, support mechanisms. So we want, for example, if you're an NCD patient and you're treated, you can be treated at any health facility in Fiji. So we want to, at some point in time, come to a place where any clinician, at least at a certain level, will be able to treat individuals and put them through the system and get them going. Because of that lack of capacity on the ground, we're unable to link early. And, people literally can change their minds within minutes and hours. Okay, I've been referred to this clinic. Am I ready to step in? And sometimes that step in doesn't happen, unfortunately. They probably before they die. I'm like, it could be en route to something else. So those weaknesses is something that we've identified by crunching a bit more of that linkage to care data. And those unknowns is something that we've found also by like just with the delayed linkage to care or never linkage to care. There are people who've died in Fiji, sometimes not even knowing their status, unfortunately. And we've had some scenarios where babies have died on us or diagnosed in the intensive care in pediatrics in PICU. And then we've diagnosed parents, unfortunately. This has happened. So one of the reasons why we're saying, and for us, prevention of mother to child is a big opportunity we need to leverage on, because in Fiji, about 99.9% of our pregnant women turn up to health facilities for delivery. That 0.1% or so, 0.01% are just women who probably just give birth before arrival or something. So yeah, it's multiple reasons, I'd say.
And is that unknown fraction stable, or is it growing over time, or
It's growing over time. It's something that's been cumulative, but you'd look at the 2024 data in itself, we had a good almost 50% unknown.
Yeah.
And one of the things I did mention when I was sharing the linkage to care data, that, for example, if you're tested in blood bank, and I counsel you as a pathologist and say you need to go to care for HIV to this particular clinic, people never turn up, or they say, I don't want to go. They're not ready because they're not probably appropriately counseled at that point in time. So yeah, so there's breakage in that proper counseling in care as well.
And perhaps around declaration of status as well by turning up to those clinics. Yeah.
Yeah.
So Sky has a question. So she says, thank you, Rachel. Are there any peer-driven self-testing programs?
We don't have a peer-driven testing program as yet, but it's part of our Global Fund program that we've gotten into. We've gotten back to Global Fund this year again. 2024 was our first year after almost a decade. And we've put peer testing in place, but obviously we need to capacity build. We do a certain level, but it's not peer-to-peer. It's more so we've decentralized point of care through universities. For example, we've got some universities that have clinics that do testing, point of care testing, and then do the referrals for confirmation. But we haven't stepped out to peer, but it's in the process as we progress. And we do involve our larger key population group, the LGBTQ population, in that training of point of care testing and rollout. So this is something that we're really building up. It's an opportunity we hope to leverage in.
As well as the unlinked to care, there was a large percentage of people who are unsuppressed. Would you like to speculate or tell us about what you think the drivers of that are? Do you think that's compliance? Do you think it's resistance? Do you think it's lack of education? Is it stockouts? What do you think the drivers of that are?
I actually forgot to mention, when we talk about suppression, while we have a good number of individuals that may be suppressed, there was a period of time we ran out of viral load testing kits, and they came in months later. So those things contribute, obviously. And one is obviously screening them in an appropriate, timely manner. And having said that, decentralized viral load testing we never had. But we've got it now. Just last month, we rolled out viral load and EID testing in the divisions. So they're decentralized now and more accessible to individuals, for example, in the Northern Division and Western. Otherwise, all samples were coming to a central division here in the city to be tested for viral load. And we know the sample needs to be at least collected within the 24 hours to be able to do that proper. So I think stockouts, now decentralized, centralized testing was an issue. So we anticipate to see that gradually increase.
Thank you. So there's no more questions in the box. So Rachel, thank you for a really excellent presentation with that sobering message. And we wish you luck and all our support in any form that we can deliver it in facing and surmounting this challenge. Thanks very much.
Thank you. Thank you so much for the opportunity.
We'll close it there.